We started a MRI program in my previous institution, and certainly there was a learning curve. I would say that some of our colleagues across the pond have bet pretty heavily on MRI and actually moving towards studies, properly done studies with office biopsies, to confirm that they have, in fact, bladder cancer plus MRI. And if it's convincing enough, that's grounds to move towards, chemotherapy followed by cystectomy or chemoradiation. But it doesn't sound like you're sold on that paradigm quite yet.
Well, yeah, I look forward to seeing the studies. I think it's a different era. What I did was over 10, 15 years ago. And I'm sure things have changed. As you mentioned, we now have VIRADs. And even if you look at that original paper on VIRADs, again, a number of times it changes your management, I think is very low. And also, it's pretty provocative to go directly from percutaneous biopsy, for instance, directly to neoadjuvant chemotherapy. There's a lot of information we glean from a TURBT, but that's what studies are for. I mean, I think that's a very well thought out design study, and I look forward to seeing the answers. I know that TURBT is a fairly morbid procedure, and patients suffer quite a bit from it. So if you can potentially skip that, all the better.
Yeah, in the various venues that I've trained and practiced, there's always kind of that quarterly M&M of a TUR gone somewhat wrong, an anesthetic complication, this, that, or the other. Now, what about if the patients are coming in with hydro? In your mind, is that by definition T3 disease?
Uh, yeah, it's a great question. I think for the most part, the answer is yes. I don't think that's always true. Seth Lerner and I always have this discussion back and forth about clinical staging of bladder cancer. Look, we do a terrible job doing clinically staging bladder cancer. We're wrong at least 30% of the time, right? And hydro, by definition, to me, is almost certainly muscle invasive, not necessarily T3. I think in many instances, it's not necessarily outside the bladder wall into the perivesical fat, but rather just invasive into the muscular layer that's obstructing the ureteral orifice. So almost by definition, muscle invasive and most likely T3, but not necessarily.